Good afternoon, everyone. Today, as you can see, we are going to talk about meningitis. So, bacterial meningitis. What happens in the meningitis is a infection of the meninges, right? So, do you know about the meninges? How many it conclude, right? Three, right? What are the names? Can you tell? Okay, it contains the here. Let's say this is the brain part, okay? Skull, it covered by the skull, and here the dura mater is there. Yeah. Uh, this one, right? Or this one? Which one? This one or this one? This one, right? Okay, very good. 5 points. Dura mater, pia mater, dura mater, and let's say this one is a arachnoid mater, right? So, all arachnoid mater. So all these are called the arachnoid space, right? Subarachnoid space. So this is where the infections occurs, right? How does the infection occurs? Like suppose the blood, when the blood enters to the brain, infections happens into the cells, right? Inside the blood component. So when the infection is there, then the CFS fluid viscosity increases, so which indicates that inflammation is there. So the infection occurs like different parts, like different types, bacteria, viruses, fungi, and influenza as well. But today we are going to talk about bacteria. So, and what are the symptoms of the bacterial meningitis? Can you tell? Photosensitivity, neck rigidity, yes. Headache is there, yeah. Four main types are there: neck rigidity, fever, photophobia, and head, headache. Yeah. No, you guys might have neck stiffness. You don't have meningitis. Okay, that's because of phone. Text neck. Okay. So we will. How will you diagnose a person is having meningitis? CSF fluid culture. From where you'll take? Lumbar region. Very good. Okay. So what are the main indication in the what is that? In the blood reports, what are the main things we have to look? WBC, differential counts, yeah. Monophils, neutrophils, CRP, yeah. And one more thing, you forgot, starts from P. Protein, very good. Okay, we'll talk about the antibiotic therapy. So based on the patient factors, this one I take it from the US Pharmacy Association. So if you want, you can double check. I might not say everything completely. So patient factors, if the patient is less than 1 month and the susceptible organism is Streptococcus agalactia, E. coli, Escherichia coli, Listeria monocytogenes. So the antibiotic therapy to give is the ampicillin or cefotaxime or aminoglycoside. And 1 month to 23 months, like same as Agalactia, E. coli, and pneumonia, S. pneumonia, and Neisseria meningitidis. So you have to go for this one. 2 years and 50 years, it's same. Actually, the treatment is same, but the susceptible organism might be different. But as you can see here, in 2 years to 50 years, it's pneumonia and meningitis, Neisseria only. And so vancomycin along with cefotaxime or ceftriaxone, whichever possible based on the susceptible organism. You have to choose cefotaxime or ceftriaxone, and you can add ampicillin. And in some expert, they give dexamethasone as a anti-inflammatory as a prophylaxis. So when they are using rifampicin, both. And if patient is old, like 50 years and above, pneumonia and the susceptible organism, as you can see, pneumonia, meningitis, monocytogenes, and gram-negative bacilli. You can use vancomycin plus ampicillin along with cefotaxime or ceftriaxone. So coming on to the dosage on the adult, this one is adults and this one is pediatrics, yeah. Ampicillin is given in 2 grams IV in every 4 hours, and divided dose for pediatric is 300 to 400 mg per kg per day IV in every 6 hours, and cefotaxime 2 grams IV 4 to 6 hours and 225 mg to 300 mg per kg per day and every 6 to 8 hours. So like coming to ceftriaxone, 2 gram IV every 12 hours, 50 mg per kg per IV, and every 12 hours. This all two are like divided dose for the pediatric. And coming to penicillin, 4 million unit IV Q every 4 hours, and for pediatric 300,000, that's 3 lakhs units per kg per day, and IV intravenous in every 4 hours and 6 hours. Trimethoprim and sulfamethoxazole 5 microgram per kg per dose, or trimethoprim component in every 6 hours. So 10 to 20 grams in pediatric dose and per kg, and every 6 hours and 12 hours. So coming to vancomycin, we have 15 mg per kg to 12 mg per kg IV and every 8 hours and 12 hours. This one vancomycin, it can be varied based on the protocol treatment algorithm. It depends on like places. Like in US, it might be different, or in India, it might be different. This one, so and coming to pediatric, 60 mg per kg per day and every 6 hours, and maintain the trough level of 15 microgram per ml to 20 microgram per ml.